Welcome to all, and Bart, the floor is yours as the chairman and the first speaker.
So my name's Bart LEROY. I'm a clinical geneticist and ophthalmologist who works in Ghent, Belgium. I am the working group leader in ERN-EYE, led by Helene Dolphus, and I am the lead of the working group 1 on retinal disorders. One of the things that I've been doing in my life is a lot of work in Marfan Syndrome and allied disorders. I have two fantastic colleagues whom I'll be introducing later on, Elke KREPS and Julie de Backer. But first, the eyes in Marfan Syndrome and allied disorders. I'll quickly introduce the topic to you. And the human eye, for those in cardiology, obviously you don't remember every detail of the eye, but the lens is actually suspended by a suspension ligament, 360 degrees around the lens, and those suspension ligaments actually support the capsule in which the lens is located. We see at the back of the eye the retinal, which is the light-sensitive film, as you know. Now, we'll be very quickly introducing Marfan Syndrome, Ectopia, Lentes, and Pupillae, Cohen Syndrome, and then just a touch upon a couple of others. But Marfan Syndrome is the more important bit of what we'll be addressing today. So 41% of the Marfan patients, according to one study, and others have confirmed that, are initially seen by eye doctors. And so eye doctors are people who can make a diagnosis if they have the right reflexes. Now, Fibrillin 1, which is the gene product of the FBM1 gene, people with Marfan syndrome have one mutation in copy, as you probably know. Fibrillin 1 is found in zonules, so the suspension ligament of the capsule, but actually in every other structure that you look at, you will find, to some degree, you'll find fibrillin. This is very important because this is a whole eye disorder that does present itself mostly with a lens subluxation. Lens subluxation, or Ectopia lentis, which is the lens that has moved to one side, has been mostly seen in Marfan syndrome, in the sense that when you look at all cases of Ectopia lentis, Marfan syndrome is the more prevalent cause. People have put numbers on that, 55%, 62%, suffice it to say between 50 and 70%. Most of the time the lens moves in the superior direction, but others are possible. Now, lens collobometer can also be seen. These are, in my view, defects in the formation of the lens because the pull from the zonular fibers onto the inferonasal point of the lens is insufficient during the genesis of the lens, and that's why you keep that indentation in the lens rather than forming a beautifully circular lens. Other things have been shown: a flat cornea, you can have increased axial length, retinal detachments are more frequent, and myopia certainly is as well. Lens dislocation and myopia have been held as factors in the Ghent nosology on what Marfan syndrome really is. And here you see some examples. This is a technique that we use, a retro illumination, where we use the slit lamp to highlight the lens using the red reflex coming off the back of the eye. And you can tell where the border of the lens is. You can also see some abnormalities of the pupillary margin that can be typically seen in Marfan syndrome. And another one with what is called a coloboma of the inferior part of the lens. Again, these little zonular fibers that you can see at the bottom here don't pull enough. We do think that the inferonasal part, where the eye closes last, when the eye is formed as the optic cup and then moves into being an eye globe, it's inferonasally that this happens last, and we think that therefore the fibers at that level are the least capable of pulling on the lens in its formation. Here you see some retinal vascular tortuosity, which can also be seen in Marfan syndrome. This is a very minimal lens subluxation, as you can tell. You can look under the lens when the patient looks inferiorly. Here you can even see with this magnification the imperfect zonular fibers in a lady 36-year-old with a proven mutation in the gene. This is a young boy with congenital Marfan syndrome. I'm pretty certain that Julie will be alluding to it later on as well. And he had also some degree of optic nerve dysplasia. The Ghent nosology, first Berlin, then Ghent nosologies, have decreased in the importance of what is the ophthalmic part, but still we are mentioned, and with Ectopia lentis being still an important bit in the diagnosis, we cannot forget that Ectopia lentis is a major sign of what is Marfan syndrome. So Marfan syndrome is not the only condition where you can see Ectopia lentis. Ectopia lentis at pupillae per se as a diagnosis is also an option. And this is a recessive condition where you can just have Ectopia lentis, but you can also have ectopia or an ectopia of the pupil. It's a recessive condition with lens subluxation and pupillary displacement, which is mostly opposite to that of the lens. It is bilateral, but very asymmetrical often. There are no systemic features in contrast to what you see in Marfan syndrome, and Julie will again be alluding to that. Now, variable expressivity may occur within one family. You can have Ectopia lentis in one individual, and another individual may have the Ectopia lentis at pupillae. Biallelic mutations have been shown, so this is recessive, as I said, in either ADAMTSL4 or LTBP2. Here you see, for example, 3 patients of the same family. You can tell that the right eye at the top left-hand corner, the right eye and the left eye pre-dilatation are visible. But then after the dilatation, whereas you initially think that in this young gentleman, the right eye is normal, you can tell that when he looks down, you can see that the lens is actually far from normal. Inferiorly, there is an abnormality. And again, this is something that you can only tell when you have dilated examination. The lens in the other eye has completely moved upwards in the opposite direction as has the pupil. And there are even abnormalities at the level of the back of the eye. As you can tell, these are things that are not logically described or not frequently described in the literature. I'm not going to dwell on the rest in the interest of time. This is a gentleman with Ectopia lentis in both eyes. The lens is interactive, so it's become a bit opacified in the 66-year-old gentleman who is homozygous for a mutation in LTBP2. Cohen syndrome is another condition that can actually give you a combination of mild to severe psychomotor retardation. They are oftentimes at the motor level very clumsy, and they have a microcephaly with characteristic facial features, and they have these long tapering fingers that are very typical if you've ever seen them. They can have hypotonia and joint laxity. Sometimes they have neutropenia. They have a cheerful disposition. They're very much happy children, the Cohen syndrome cases. They have high myopia, and progressive retinochoroidal dystrophy is often seen, and they're due to biallelic mutations in the Cohen1 gene. So this is, for example, a patient who is positive for mutations in that gene. There are very few patients in the literature, and not all of them have Ectopia lentis. This is the young girl that I was talking about, and for those in the know, the retina doesn't look normal at all. This is a typical aspect of a retinal dystrophy, which she does have, and several of those patients have indeed not only lens subluxation, more of them actually have retinal dystrophies. So there are other conditions, and this is just a short list before I lend the floor to my colleague Elke. Well, Marquesani syndromes with mutations potentially in several genes are conditions that give you Ectopia lentis. homocystinuria, which we don't often see anymore, give you a mostly inferior subluxation of the lens. Trabulsi syndrome, a very infrequent condition. You can tell from the photos. This is from a recently seen Trabulsi syndrome patient in Ghent. And then the series of Louis-Dietz syndromes can have abnormalities. Some people think that there might be Ectopia lentis in some of them. I've personally not seen them in these patients, but you never know. We keep an eye on that. I'm pretty certain that Julie may allude to them. So what are the general advices or general conclusions regarding Ectopia lentis syndromes, including Marfan syndrome? I would say that not every eye doctor looks at a Marfan patient the way that people do when they really are exposed to a lot of patients with Marfan syndrome. Every eye doctor can potentially do this, but they don't always go into detail the way that university eye doctors do this. And it is important to understand that you cannot exclude Ectopia lentis if you have not made the patient look down and you have fully dilated the pupil. In some normal people, you can actually look under the lens if the pupillary dilatation is absolutely maximal. But this is not frequent. And surely when you can see under the lens and you have this indentation that is clearly a sign of what I call very mild Ectopia lentis actually, or abnormal formation of the lens due to insufficient pull of the zonular apparatus, you have to conclude that there is something wrong in the fibrillin or fibrillin pathway. So serial slit lamp photography with retroillumination is essential if you want to follow them up, because the evolution of Ectopia lentis is also very infrequent. I have a lot of people that I work with, some of them listed here. I am certainly not, as a clinical geneticist and eye doctor, the only person doing Marfan work in Ghent. You'll see that in Elke. You'll see Julie later on talk about the cardiological aspects. And with that, I'd like to push the floor to my colleague Elke whilst she's sharing the screen and preparing her talk for you to listen to. Please allow me to introduce her. So Elke is one of my high-flying staff members, young and incredibly capable. She's a very, very scientific eye doctor, one of my staff members. She writes MD, but she nearly can write MD, PhD in a couple of weeks. It's not even a couple of weeks. She'll be an MD, PhD. She is very capable, and she'll be telling you about new things that she's been able to discover. What's the future of how we look at Marfan in the eye? Elke, the floor is yours.
Thank you, Bart. Thank you for that lovely introduction. As Professor LEROY said, I work alongside him at Ghent University Hospital. I'm affiliated with Antwerp as well. I mainly focus on the anterior segment of the eye. So that is what my talk is mainly going to be about, namely the two ocular structures that, by virtue of their very intrinsic and intricate structure, are transparent and are the two major refractive units of the eye, the cornea and the front, and the lens sort of halfway through the eye. Now, for a long time, we've known that the cornea, and specifically the corneal geometry, is different in a Marfan eye. So classic features that have long been described refer to the very central part of the cornea. So typically there's sort of 3 millimeters of central cornea. We've known for a long time that that cornea tends to be a bit flatter than normal and tends to be thinner. Now, over the past 20 to 30 years, the way that we've been able to image the cornea has evolved immensely. So on the left, you can see what we used to do is basically a technique in which you use concentric rings, which were referred to as placido rings, which were projected on the cornea. and the reflected rings were analyzed, and based on that, we created a map of what the cornea looked like. So that basically only provided sort of a rough idea of what the anterior cornea looked like. Now, on the right-hand side, you see what we can now use in corneas, which is basically a tomographic analysis, much akin to what a CT scan does. So what you create is an optical cross-section, in this case with a blue light emitting diode, which actually allows to make an optical cross-section of both the cornea, which you see here, and this is actually an optical cross-section of the entire lens. Now, by virtue of the fact that these are transparent structures, this actually allows to visualize them. And this has greatly expanded what we know about normal eyes, but also what we know about Marfan corneas. Now, the two changes in geometry that we've known for quite some time actually appear to not only involve the central cornea, but the flattening actually also occurs in the peripheral cornea and even in the anterior sclera. This is some recent research that we did last year, that we published last year, with the use of a corneoscleral topographer, which actually allows you to create like a land map of the entire surface of the anterior eye. And that was clearly completely different in Marfan patients as compared to controls. The flattening effect also is seen in the posterior cornea as well. And likewise, the cornea is not only thinner in its central part, but also thinner in across the entire cornea, including the corneal periphery. Now, why is this relevant? Now, this is mainly relevant in terms of contact lens fitting. So the patients with Marfan syndrome very often have refractive errors, myopia and astigmatism that require optical correction. Now, you can correct it with glasses, you can also correct it with contact lenses, but these changes in geometry mean that the standard contact lenses, especially sort of the over-the-counter ones, will not provide a good fit in these eyes. So you will need different types of contact lenses, and especially different parameters to fit these eyes. The corneal thinning makes them, is one of the reasons why these eyes are not good candidates for refractive surgery. So there's something to bear in mind when talking to patients. Now, some of the research that we've currently been working on is sort of further typifying the corneal changes in Marfan syndrome, sort of beyond the geometry. And so for the sake of the cardiologist, I'm not going to go into all too much detail. Now, what the recent data actually shows is that the way that light passes through a cornea is different in a Marfan cornea as compared to a normal cornea. So what you see is that the light that actually travels through it, a small proportion of it is being backscattered. And what you see is that in a stroma of a Marfan patient, more light is actually being reflected and being backscattered than in a normal patient. Now, if you have a look at experimental research that has recently been done in mouse corneas that actually have a heterozygous, so in mouse that have a heterozygous Fibrillin 1 mutation, is that you not only see a very much disorganized elastic microfibril bundles within that cornea, but that the abnormal fibrillin actually changes the collagen ultrastructure as well. And it's that collagen and its very specific diameter of the fibrils and very specific distance in between collagen fibrils that actually makes a cornea transparent against all odds, because connective tissue doesn't tend to be transparent. But to sum it up, a cornea in Marfan does not seem to be as transparent as a normal cornea because of these indirect changes to the collagen ultrastructure. And there's a lot of ongoing research to fully sort of understand what the link is between the two. Now, the most characteristic feature, of course, in Marfan is this lovely picture that you see here with a crystalline lens that is slightly dislocated, and these zonular fibers, which you can clearly see and which are quite extensively stretched. Now, this is inevitably a very tricky thing to manage as an ocular surgeon. And in a number of cases, we need to actually do surgery in these eyes. About 60% has a dislocated lens. And if the lens dislocates too far off axis and off center, you can no longer actually provide them with good vision and you need to do surgery. But also patients with Marfan syndrome actually tend to develop cataracts, which are lens opacities, at a much earlier age. So you are sometimes obliged, even in patients who don't have a very pronounced ectopia lentis, you may need to do surgery in these eyes. In children, it's a bit of a different scenario. Your threshold is a lot lower because children under the age of 10 can develop amblyopia if they never get a good vision in their eye. Now, there are basically two scenarios and two approaches as to how you're going to manage the lens. Now, the first scenario is, for instance, this eye, which is an eye in which the lens is not as transparent as it used to be. So it's developed cataracts, but it's actually not that far off axis. So it's quite centered, but you can see that these zonular fibers here inferiorly are not as well as they should be. So, you know, if you do standard cataract surgery, you will have a very wobbly lens while you're working on it, and you will very likely end up having complications. Now, luckily, we do have a number of sort of surgical aids which can help actually replace the function of these normal zonular fibers. And these lovely things are called capsular hooks. Now, what you do with these hooks is actually, after you've made a circular opening in the capsular bag where the lens is in, you use these hooks to just hook under the rim of the capsule, and you normally attach 4 of them. And these actually replace the function of normal zonular fibers and make sure that while you're removing the contents of this bag, the lens doesn't wobble every single time that you work on it. So this markedly reduces the surgical trauma that you induce by wanting to remove the lens material. Now, a second lovely aid is this little capsular tension ring, but the modified version of it. Now, a capsular tension ring is actually it's a flexible ring that is being inserted within an empty capsular bag. So this is actually the anterior opening of the bag. We've already removed all of the lens material. But if the lens was already decentered, if you only put an intraocular lens in, you'll just have an decentered intraocular lens. So these bits actually help to provide centration of your intraocular lens. You put this ring within the capsular bag and it puts tension on the equator of the lens, so that actually the tension on the zonules is more equal across the whole 360 degrees. And then this sort of fixation hook is actually, as you can see here, it's not in the same plane as the ring. So you actually maneuver this fixation hook anterior of the capsular bag, and then subsequently put a suture through this eyelet and then attach the suture to the scleral wall. And that way you can actually center the entire bag to the scleral wall and just put a intraocular lens within the bag. You've also got models which have 2 of these fixation hooks. They're the ones that we typically use for Marfan patients, so that you can actually attach the entire capsular bag to the scleral wall in 2 areas. And this is sort of what it looks like following surgery. So this thingy here is the intraocular lens, and these are the sutures that are actually at which the eyelid is sort of attached to the scleral wall. And this provides a very nice centration of the lens. Now, this is not always possible. If the lens is too far off axis, you can't do safe surgery. And then rather than sort of accessing it via the cornea, so via the front of the eye, you can go more posteriorly via the vitreous and actually remove the lens from behind and remove the central part of the vitreous, which is called a core vitrectomy. Now, if you do this type of treatment in young children, so 5, 6, 7 years old, we tend to wait to put a lens implant in until they're a bit older and the lens and the eye has grown a bit more, to then implant a secondary lens at a later age. Now, it is still very much a matter of debate which type of lens you ideally insert in these patients. This is what we used to do. So this is what we refer to as an anterior chamber IOL, an anterior chamber intraocular lens. So this is sort of the optical bit that is placed in front of the pupil. So this is what people use for vision. And these are sort of the haptics that rest within the angle of the eye. Now, the problem with these types of lenses is that a Marfan eye, especially a Marfan anterior chamber, is on average a bit larger than that of a normal patient, which means these lenses are actually poorly adapted to fit in a Marfan eye and tend to shift quite a lot. When the haptics shift, they tend to sort of rub against the iris tissue, and this causes inflammation, can cause recurrent bleeding in the eye. So this tended to have quite a lot of complications beforehand. The two techniques that we nowadays use, and it sort of depends a bit on the surgeon and depends on the eye, which one of the two is the most ideal. So on the left, you see what we call an iris claw lens or an iris clip lens. So this is a lens also positioned in the anterior chamber, so anterior of the iris, in which you clip it to the iris stroma. You can also position these lenses posterior to the iris and clip them to the posterior surface of the iris. And then the second approach to it is actually position the lens in the posterior chamber, so posterior of the iris. But instead of suturing the capsular bag to the sclera, you actually suture the haptics of the IOLs to the sclera. Now this, theoretically, you actually position a lens in the posterior chamber, so in a very similar place as where you normally have your lens. The downside to it is that scleral fixation in Marfan patients actually has quite a high complication rate, and it tends to dislocate a lot more frequently in Marfan patients as compared to normal patients. Now, in some of the research that we've done, we've seen that the shape of the sclera is completely different in Marfan patients, which is likely the reason why they tend to dislocate more frequently. And especially in children, you see that the sutures don't tend to last. So in up to 1 in 4, they need repeat surgery to actually fixate it again. Now, in whatever shape or form you do surgery in these eyes are, especially following cataract surgery, they have a markedly increased risk of retinal detachment. So either way, you do need to provide a regular follow-up, especially following surgery, to be able to detect complications related to the surgery. Now, I'll keep it at that. Likewise, I do have a lot of people to thank for their collaboration, and I will give the floor to Julie, who'll talk a bit more about the cardiology side of Marfan syndrome.
Thank you, Elke, for a brilliant talk. I think you've generated quite a bit of interest. And this session is I think, a first, which is a joint session of ERN-EYE and our colleagues from the vascular diseases, ERN, Vascular. Julie is a longtime friend and colleague, an absolutely brilliant cardiologist, but also clinical geneticist. So double-boarded. And did her thesis in the old days on Marfan syndrome, is one of our national treasures on Marfan syndrome, very much the lead at Ghent University in Marfan syndrome. Julie, I'm going to allow you to update us on general and cardiovascular aspects of Marfan. I just want to tell you, if you run over to all in the audience, I don't mind. I've actually put this webinar at far longer in the Zoom meeting. So I would say just carry on as long as you want to go for. We might have questions at the end. I'm definitely staying. Okay, thank you.
Thank you very much, Bart, for this very kind introduction. You make me blush. So indeed, this is a joint webinar between ERN-EYE and our colleagues from the Vascular group. And I want to thank the people from the ERN-EYE for the invitation and for the initiative. I think this is very important that we do these things together. We are all dealing with rare diseases that have manifestations across a broad spectrum, and I think collaboration between the ERNs is very important. So I'm going to talk about some general and more specifically about cardiovascular aspects of Marfan syndrome. I will start with some general aspects about diagnosis, epidemiology, and some genetics, to move then to the cardiovascular features, and then end with some future directions. These are the two main gentlemen in the field of Marfan syndrome who have put the disease on the map. So it is the French pediatrician Antoine Marfan, who has described the syndrome for the first time, although there's some discussion now as to whether this actually was Marfan syndrome, but I'm not going into those details. And then there's Victor McCusick, who has really put the syndrome down into a very important textbook on connective tissue disorders in the past century. Bart has already mentioned this. So the diagnosis of Marfan syndrome, even at this day, is still based on clinical criteria, and these are defined in the revised Ghent nosology. And Bart has already alluded to this as well. The importance of the ophthalmologists here is very crucial, since Ectopia lentis plays a capital role in diagnosing Marfan syndrome, as you can see. And there's a distinction between situations where you have no family history of Marfan syndrome, so where you will look at aortic dilatation, which will be defined with a Z-score. And if you have that combined with Ectopia lentis, you can confirm the diagnosis of Marfan syndrome. If you have a confirmed pathogenic variant in the Fibrillin 1 gene, you also have a diagnosis. And then there's a systemic score that we use, addressing mainly skeletal features. This, in combination with aortic dilatation, also leads to Marfan syndrome, as is the case for Ectopia lentis with a Fibrillin 1 mutation known to cause aortic disease. There's a little difference in the case of a presence of a family history. So in those cases, the criteria are a little less stringent, as you can see, but Ectopia lentis still plays an important role. And here you can have situations with systemic scores and a positive family history, or aortic root dilatation and a positive family history, which will lead you to your confirmed diagnosis. Regarding the epidemiology of the disease, so there's various estimates of the prevalence ranging from 1 in 5 to 1 in 15,000. You need to be aware of some caveats here. There may be some underestimation, because not all cases of thoracic aortic aneurysm with or without skeletal or ocular features will undergo Fibrillin 1 testing, and so this will lead to underestimation. And there, on the other hand, there may be an overestimation in some reports as well, because, and Bart has also already mentioned this, there's various other syndromes that are Marfan-like, and in which some patients may even meet the criteria for Marfan syndrome, but who have variants in other genes, and these are sometimes included in reports and may lead to overestimated estimates of prevalence. We need to be aware of the fact that 25% of the patients will have what we call a de novo mutation, meaning that neither of the parents is affected and that a new or spontaneous variant has occurred. As already mentioned as well, there's a very high clinical variability, even within the same family carrying the same variant, and there's important age-dependent expression of many of the features of Marfan syndrome. Now, just some brief words about genetics. So Marfan syndrome is caused by pathogenic variants in the Fibrillin 1 gene. This is a very large gene, 65 exons in total, and more than 3,000 different pathogenic variants have been reported so far. So basically, each new patient, each new family has its own private variant. So this makes genetics testing challenging, since you always have to screen the entire gene to find the causal variant. This is just an overview of the structure of the gene, and these are data that have been reported by my colleague Laura about the spectrum of variants that you may encounter. So there's different types of mutations, and what is important to know here is that there, in the middle of the gene, there's a so-called neonatal region of the gene, where if you have a variant in that region, there is a risk of having a severe form of Marfan syndrome, neonatal form of Marfan syndrome, with a much poorer outcome than in the classical form of the disease. And then regarding the types of mutations, it's important to know, and I will come back to that later in the presentation, that there's various types which can roughly be divided into the missense or in-frame variants, and which do have a dominant negative effect on the protein, so a decreased quality, whereas the premature termination codons, or the stop codons, will lead to a haploinsufficient effect with a decreased quality of the gene. This is gaining increasing interest, righteously so, I believe, because there seems to be some genotype-phenotype correlations that I will address in a minute. So people who are familiar with genetic diagnostics know that there's a spectrum of variant classification, going from the class 5, definitely pathogenic variants, over to the benign variants, which are class 1. The big bunch of variants that occur throughout our genome are very often variants of unknown significance. These are really a nuisance to all people working with genetics, and it's sometimes very difficult to link these variants to the disease, and there's work to be done there to improve our assessment of these variants. And this is again from the work from Laura, who has looked at the classification of the variants and set up some FBN1 specific tailored criteria, where she did see that there was an increased amount of these class 3 or these variants of unknown significance, and a slight decrease of the pathogenic or the causal variants. So there's definitely work to be done to improve the classification of the variants. As already mentioned as well, so there's the Fibrillin 1 gene can be linked to other diseases, and one important other disease is the familial Ectopia lentis syndrome, where you have Ectopia lentis but not the other features that are reminiscent of Marfan syndrome. And in the same spectrum, we also have this entity of non-syndromic heritable thoracic aortic disease. So meaning that you have the aortic features, but not the systemic features that commonly occur in Marfan syndrome. And it has been demonstrated in different studies, one of which is shown here from the French group, who have analyzed the various genes associated with the syndromic forms of thoracic aortic disease, and found that in quite a proportion of these patients, you may encounter FBN1 pathogenic variants, meaning that you do not always have the full picture of the disease. And this is very important to cardiologists to know that even if in patients who do not have lens luxation skeletal features, that you still need to think of the FBN1 gene. Now, these are very nice data reported by our colleagues from France, where they have looked at, and I have mentioned this, so there's this these different types of variants, so the PTC variants versus the in-frame variants, and they looked at relatives and probants. And what I want to show here is that when you look at Ectopia lentis surgery, that your risk, if you have an in-frame variant, is higher when compared to those patients who have PTC variants. And this holds true for both groups, so both for family members and for probants. And the risk is even higher here in the probants if you have a loss of a cystine. So this indicates that there is some degree of genotype-phenotype correlation that we may in the future use to estimate the risk for a patient, not only for the ocular features, but this can also be used for the cardiovascular features, as I will show you in a minute. So moving to the cardiovascular aspects of Marfan syndrome, and it is without any doubt that we need to start with the aorta, which is the main affected vessel in Marfan syndrome. And just to introduce you, I promised to be gentle to the eye colleagues, so I'm going to introduce you to thoracic aortic disease in this slide. So the thoracic aorta is part of your aorta in your chest, and the problem in most patients with Marfan syndrome is located in the what we call the aortic root. So this is just above the aortic valve, where you have this structure that is always slightly dilated in everyone, but which may be aneurysmatic, so meaning that you have a very severe dilatation of the aorta at that part, and this is like a balloon that you blow, and it goes without saying that with increasing pressure in the wall of that balloon, the risk for dissection will increase significantly. And this is what is most feared in Marfan syndrome, so thoracic aortic dissection, which is still, even in the current era, associated with a high acute mortality of 25% and a 30-day mortality of 50%. So it's paramount to avoid this situation, and treatment has been very much focused on that aspect. Looking at why do people develop aortic dissection, and so in our Western world, aortic dissection is very much linked to common atherosclerotic disease, meaning that this risk is higher in males than in females, higher in smokers than in non-smokers, higher in hypertensives, and higher with increasing age. But when you look at Marfan patients, you see that these curves, both in males and females, shift. That the scale on the y-axis is quite different. It's times 100, as you can see, and there's about a 30-year move of the risk for aortic dissection when compared to the general population. So, well, aortic dissection is the feature that we need to avoid in patients with Marfan syndrome. And fortunately, and this is not seen in cardiology, there's no cardiovascular disease where there's such a dramatic improvement in survival as we see in Marfan syndrome. These are already very old data, as you can see in the graph, but these compare data from the early 70s to the early 90s, and you can see there's a significant shift in survival thanks to improved diagnosis and treatment. But still, as you can see, there's a risk, especially in the early stage of the disease. And there, to estimate this risk for dissection and for fatal outcome, we have some known parameters there. So the aortic root diameter plays a very crucial role there. With increasing diameters, your risk for dissection will go up. There's, as I already mentioned, there's very likely specific variants in the Fibrillin 1 gene that will put you at a higher risk. There's sex and pregnancy that play a role, and I will come back to that in a minute. And then there's some additional risks, and these are the extra aortic features that I will come back to in the next few slides, that can also cause increased mortality and morbidity, being arrhythmia and cardiomyopathy. So the aortic root diameter, as I mentioned, is really the most important parameter that we follow in patients with Marfan syndrome. And as shown here in these data, again from the Paris group, you can see that the risk for dissection will go up with increasing diameters of the vessel. And this, I'm not going into the details here, but I mentioned dissection of the aortic root, which is a type A dissection. You also have a risk for type B dissection. So this is in the distal part of the aorta in patients with Marfan syndrome. And there's no difference here, as you can see. Both type A and type A dissection risks go up once you reach diameters above 50 millimeters. These are again data as from the publication that I showed you for the variant risk related to the Ectopia lentis. These are the cardiovascular or the survival and the aortic dissection risks when comparing again the types of variants, so the in-frame variants versus the premature termination codons, and you can see that there's a clear difference here. And the same holds true for aortic dissection or surgery, where you can see that people harboring a PTC variant have a more severe or a more a less favorable outcome than patients with an in-frame variant. And these data will or are already useful in counseling our patients when we have to estimate their risk for dissection. Coming to sex and pregnancy, as is often the case in cardiovascular disease, men have a disadvantage when compared to women, and this is also the case in the setting of Marfan syndrome, and this has been studied extensively. This is known in human cohorts, but these where you can see data in men and in non-pregnant women where there is a difference, I can tell you, and that this difference disappears when you look at the pregnant women. We have looked at this, and this is work from my colleague Marjolein Renard, who has looked into a mouse model where you can clearly see the abnormalities in the aortic wall of male mice. You can see similar abnormalities in the wall of female mice that have been used for breeding, so who had pregnancies, and you can see that, well, there is some breakup of the elastic fibers for sure, but it's much less pronounced in the mice that have not been used for breeding. So there is a difference between men and women, and as it looks like the pregnant female mice at least show similar differences as their male counterparts. So we know that pregnancy is associated. This is not only the case in Marfan syndrome, but pregnancy is a risk period for aortic dissection in the general population. But when looking at the risk when compared to the general population, it's a 6-fold risk when looking at people with Marfan syndrome. So definitely a more pronounced risk there. And then looking at males, there's an increased risk for aortic surgery and for increased diameters, and also for dissection, as has been shown in many cohorts. These are data from the Concord registry from the Netherlands. So I mentioned the aortic diameter, but actually the most important risk predictor in Marfan syndrome is knowledge of the diagnosis. People who are unaware, and I forgot to mention that, but an aortic aneurysm goes without symptoms, and this is really, it's like a ticking time bomb, if you like. So people may have increased diameters of their aorta, and they will not know until the moment that the aorta dissects. So it's really, really important that the diagnosis of Marfan syndrome is made before this happens. And here it's important to acknowledge that there is a difference between the natural evolution of the disease and the clinical evolution. And in the setting of Marfan syndrome, and this is a very nice publication from our colleague from Reed Periods, who has nicely shown that 30 years of research equals 30 years of additional life expectancy in Marfan syndrome. And he very nicely explains what the difference is. So natural evolution is when you do nothing or you don't know that you have to do something. And the clinical evolution is what happens when patients are under follow-up, under care, and people need to follow the recommendations, of course, but there's a marked difference when you compare those two groups. And this has been shown, again, by our colleagues from Paris. They have very large cohorts of patients with FBN1 pathogenic variants. They have over 1,500 patients there, and they showed that in those patients who followed the guidelines, meaning that they take beta blockers, they limit strenuous exercise, and in those patients where the aorta reaches 50 millimeters, prophylactic surgery will be performed. In those cases, the outcome is good and the risk for dissection goes markedly down. And when looking at pregnancy, it's a bit similar. Pregnancy outcomes in women with thoracic aortic disease, mainly Marfan patients, is good if the current guidelines are followed. So again, meaning that these women take beta blockers throughout pregnancy, that in some cases we will recommend prophylactic surgery prior to pregnancy. And in these women, the risk for dissection goes down. And those cases that you encounter with a dissection during pregnancy, most of those cases occur in women who were not aware of the diagnosis. And this is a very severe situation where you get a diagnosis of Marfan syndrome during pregnancy. You have two lives at risk there, and this is something that we need to avoid in the future. Now, I have been talking about the aorta up to now. I will briefly mention some extra aortic features that can occur in Marfan syndrome, and this is an example of what we call mitral valve prolapse. So this is a mitral valve, and normally this valve, I can tell you, is thicker than a normal valve, and it's moving more than a normal valve. So this is what we call a prolapse. And we know that 5 to 12% of patients with Marfan syndrome will require primary mitral valve surgery, so meaning before the aorta needs surgery, when compared to what we call idiopathic mitral valve prolapse. So this is something that occurs quite commonly in the general population. 1 to 2% of people are known with this, but we see a marked increased risk of clinical events, so endocarditis, surgery, and heart failure in Marfan syndrome when compared to the general population. Not only is the risk increased, the age at the event is significantly lower in the people with Marfan syndrome. Cardiomyopathy, very briefly. So we have had an interest in this feature for many years now, and we have been looking into this in humans and also in mouse models, not only us, but also other people across the globe. Marfan cardiomyopathy, meaning that the heart muscle is affected, is very mild in most cases, I can assure you, but we have seen some people with end-stage heart failure, even people requiring a heart transplantation. So it does occur in patients with Marfan syndrome. There's a link to what we call mechanobiology. So this is the mechanism by which the aorta dilates. You get an imbalance between mechanical forces, the blood pressure or valvular abnormalities, and then you have this intrinsic abnormality caused by the mutation. Oh, I'm sorry. And these are data from mice where you can clearly see that the hearts of the normal mice are much smaller, than the mutated hearts. And on histology, we also see differences. These are data from my colleague Falke Steins, indicating that Fibrillin 1 is present in the myocardium and plays an important role in the function of the myocardium. Arrhythmia is linked to cardiomyopathy, so people with a diseased heart muscle are at increased risk for developing rhythm abnormalities. There's an reported 7-fold increase for sudden cardiac death in a German study when you look at people with Marfan syndrome when compared to the general population. And here, to make myself clear, sudden cardiac death, I mean not dissection, but arrhythmic death in this case. And I just want to briefly mention this study from my colleague Laura, who has looked at myocardial function and arrhythmia in our cohort of Marfan patients, and noted that there's again mild but significant myocardial involvement in these patients with increased volumes of the ventricles, decreased function, and increased arrhythmias. This risk appears to be more pronounced in those patients with previous surgery or with valvular dysfunction. And then finally, I just want to briefly mention one feature that that has gained interest in the general population, but also in people with Marfan syndrome, and this is called mitral annular disjunction, meaning that that there's a space basically between the ventricle and the mitral annular, so the mitral annulus, and this is observed also again in the general population, but we have looked at this in our Marfan cohort and observed this in about 1/3 of the people with Marfan syndrome, and 1 out of 3 of these people had a marked distance between the ventricle and the annulus of more than 10 millimeters. And again, the presence and extent of this disjunction is associated with severe arrhythmia and mitral valve surgery. This is work done by our PhD colleague Anthony, and this definitely needs further attention and further study to confirm these data and to assess the value of this feature as a risk factor. So this brings me to the end with some future directions. So where do we have to go from here? I think in research in Marfan syndrome and in Marfan-like syndromes in heritable thoracic aortic disease, this should always be focused on patient outcome. And to improve this, there's still a need for a better diagnosis, for more timely diagnosis. There's room for improvement of risk stratification, and there's room for improvement of the treatment of people with Marfan syndrome. So what tools or what strategies can we use here? And patient registries is one very important aspect where we collect data. We are talking for ERN, so I don't have to explain that rare diseases require the collection of clinical and genetic data in order to find risk factors, as I have mentioned, the genetic factors, but also clinical factors. We can look at clinical factors in more detail. We have more detailed imaging techniques. We have some biomarkers that we can use, and we have other features that we need to develop further. And then we need to do this in conjunction with our colleagues from the lab, who will, as I have shown you in a few examples, use mouse models, not only for cardiomyopathy, but also to look at the aorta and to develop or to test new therapeutics. And one other aspect that can help us here is the study of zebrafish, and my colleague Patrick Sips from Ghent is an expert in this, and this allows for high throughput screening of new drugs that may be more beneficial and will also help us. I have mentioned the problem of classifying the variants of Fibrillin 1, if you can model fish with specific variants where you have some doubt about the causality, that would clearly help us to confirm the pathogenicity of some of the difficult variants. And as I mentioned, it's the collaboration between all these aspects and the combined work between the lab and the clinics that will hopefully help us to improve management for our patients. So take-home messages: Marfan syndrome, I hope this is clear, has many, many faces. There's a clear interplay between the genes and the clinic. Diagnosis, timely diagnosis is really key. There's a marked improvement in survival over the past decades, but there's definitely room for more and for more improvement there. And again, I started with this, we need to work together, we need to sit together and to think together to improve the care for our patients. So let's share, care, cure. This is the mantra of the ERNs, and this is where I want to end. Yeah, there's this is an incomplete list of people that work on Marfan syndrome in Ghent, and I want to thank all people from the team, and thank you for your attention.